A very warm good evening to everybody, and welcome to the first interventional round of 2025 of the Wincars Association. It gives me great pleasure. Today we have an esteemed faculty list today. We are being chaired by Dr. Mirvat Alasnag. She is Director of Cath Lab King Fahd Armed Forces Hospital, Jeddah. We welcome her into our Wincars meeting. The other chairpersons for our evening are our founder president, Dr. Jyotsna Maduri, who is a professor and head retired from NIMS Hospital, Hyderabad. Dr. Asha Mahilmaran, who is senior intervention cardiologist from Apollo Hospital, Chennai. We also have a set of esteemed panelists for our session. We have Dr. Priya Palimkar, who is senior intervention consultant and director cath lab at Sahyadri Hospital, Pune. We are also joined by Dr. Veena Nanjappa. She's a senior intervention cardiologist at Jayadeva Institute of Cardiovascular Sciences and Research at Mysore. And we have Dr. Madhumati Panja. She's consultant intervention cardiologist at CK Birla Hospitals, Calcutta. So we are joined from all corners of India. I welcome all of you today. And today we have a very famous speaker with us. Our keynote speaker for the evening is Dr. R. Anantharaman. He's senior intervention cardiologist at Kaveri Hospitals, Chennai. We have heard him many times on various occasions. And today he's going to enlighten the evening by speaking about the role of impeller in cardiogenic shock and CHIP PCI. Over to you, Dr. Anantharaman.
Good evening to the chairpersons, and firstly, a sincere thanks to Wincars for this invitation. Now, with chair's permission, today I will probably talk about the MCS in cardiogenic shock, because rather than just concentrating on impeller alone, because especially in India and also in the Asian countries, impeller is quite expensive, so we need to have access to the other things as well. So I'll talk about the MCS in cardiogenic shock today, and I'll touch upon the protected PCI. But maybe next time when I have another opportunity, I will show you case examples of protected PCI, 2-3 case examples. But today I will concentrate on the MCS in cardiogenic shock and show you a couple of examples where it made a real difference. Would that be all right, Dr. Sarita?
Absolutely, sir. Absolutely.
Share this screen. Can you see my screen?
No, sir.
Your screen, but it just says Zoom.
Oops. Yeah. 1 second. I'll reshare again.
Yes, we can see your screen, but you'll have to go to slideshow.
Now it's in slideshow?
Yes, sir.
I'll just take you through those sort of 4 aspects of what kind of MCS we use in cath labs, what are the differences between these, and what are the lessons we learned from the national sort of CSI program in US, a couple of case examples on how it's kind of made a big difference to us here. Now, there are 2 sort of pathways in terms of, especially for the impeller. One is the cardiogenic shock therapy, and the other one is the protected PCI. As I said, the left side, the protected PCI side, I will touch upon, but more details, case examples I'll show probably in the next time. The cardiogenic shock is more important. Obviously, it has got myocardial infarction or cardiomyopathy, pericardium or myocarditis, postcardial, all different sort of etiologies. But the end result is the one. And if you don't intervene early, the end result is a death spiral. So the cardiogenic shock is a very vital thing, and MCS is very vital in this one. This definition, obviously, we all know that pressure is low and you have got reduced filling pressures, end organ damage, and reduced urinary output, all those things. Now, what is important is about 40 years, more than 4 to 5 decades, we have tried various things and we have looked at in various trials, but we were not able to show a mortality benefit. We were still having high mortality in these unselected patients with shock, and it's more than 60 to 70%. So what were we doing wrong? What was the main issue? Why were we not getting an outcome, a desirable outcome in these patients? So the spiral, obviously, as I showed here, it starts, whatever the etiology, you have got the reduced perfusion, and then ischemia and end organ failure, and it's a continuing spiral. So it starts as a hemodynamic one, so reduced blood pressure, reduced output, and end organ hypoperfusion. By the time it reaches us, most of the time it is hemometabolic shock. And when it reaches a hemometabolic shock, you can see that the mortality is more than 2/3, 71% mortality compared to the hemodynamic shock. So the vital aspect of this is if we can intervene when the patient is in the hemodynamic shock before going to the hemometabolic shock, support the heart at the same time, give rest, as well as perfuse the end organs, then we should be able to improve the outcomes. So that was the background to what the National Cardiogenic Shock Initiative was. With regard to the definitions following that, obviously, we have seen this newer SPI kind of coming out with this. The at-risk population, the beginners, the classic shocks, and the ones which are deteriorating in spite of whatever we do, and the extremes. So the MCS is going to be from C onwards. The A and B can be managed with medications and with intra-aortic balloon pump support. When you reach this classic shock or deteriorating and extremis, you are going to need an MCS. And what type of MCS depends on our kind of infrastructure, as well as availability, cost, as well as the patient characteristics. That's what's going to decide. More than the first 2-3 factors, it is phenotyping the shock, and that's what's going to determine the outcomes. So what are the supports available? We have got readily available intra-aortic balloon pumps. Most of the cath labs throughout the world, we have that, especially if you're doing intervention. Then we have the continuous flow pumps, the axial flow pumps like the Impella and the PHP. And then the centrifugal pumps, the tandem heart, which is not available in India, it's available in the US. But for us, we have got the Centrimax, which are available, which can be used as a support as well as an ECMO as well. A balloon pump, as I said earlier, in the A and B stage, balloon pump is enough. So it's still not out of the sort of shock equation. If you are in the A and B stage of the shock, balloon pump is still enough. It will give augmentation of the diastolic pressure. It will give a flow rate of around 0.5. Most of the time, that's enough in the A and B stage. But when you go to the C to D and E stage, initially Impella 2.5 came, but it's out of the market because it was not enough. So either you have to give an Impella CP, that is more than 3.5 liters, or more so a complete sort of replacement of the cardiac output with the Impella 5. The difficulty with the Impella 5 is it is implanted surgically. So unless you are very good with the percutaneous axillary access, you will need a surgeon to put a graft or get an access for it. So the initial stages, we might end up putting an Impella CP and converting it to Impella 5 axillary so that we can ambulate the patient. Tandem heart, as I said, because it's not available in India, I will not touch upon that. But what is readily available is a Centrimag. Centrimag is very sort of affordable in India. In our hospital, we have it. We can provide it for around 3 to 4 lakhs, and it is a life-saving device. And it does give you a complete sort of cardiac replacement. And we can use it as an ECMO as well. So to decide what MCS you want to use for that particular patient, first you need to decide how much flow is needed. If it is in the A and B stage, if you're just going to support, then IABP is enough. Otherwise, CP or 5 is going to be needed. The second thing is, what access does the patient have in terms of the vessel, femoral vessel size or other vessel size? What cannulas we can use? Because that is going to restrict. IABP, you can use a 7 or 8 French, but if we go down the route of Impellas, you need a larger access. If you go down the route of ECMO, you need even more larger access. oxygenator. If the patient is also having lung issue, then oxygenator will be needed. And in that case, you're going to have only one support, that is the ECMO support. And sometimes you will need an RV support. I'll show you the algorithm how we decide it. In that case, the readily available RV support for us in India and Asia is the ECMO. The Impala RV is available, but it is expensive, and the tandem is not available. Protect is available in some units. So how was this put to practice in the National Cardiac Initiative, and how did we show that we can improve outcomes using all this? The first thing we learned from the National Cardiac Shock Initiative was hemodynamic monitoring is vital. That was the first lesson. You have to put a swan, you need to understand, you need to phenotype the shock, whether it is LV alone, there is RV alone, or whether it's a combination of LV and RV. The second thing is keeping on adding inotropes, 1 inotrope, 2 inotropes, 3 inotropes, before you go down the MCS route is not helpful, because the more inotropes we add, like 3 or 4 inotropes, mortality is very high. In-hospital survival rate goes down significantly. You can see if there's more than 4 inotropes, it's 25% survival. 3 inotropes is 30% survival. If you have no inotropes and if you manage with MCS, then obviously more than 70% survival. So vasopressors are bad. So more pressors, more problems. What was the third lesson learned? The third lesson was earlier we give the MCS for these patients before revascularization. When the patient is in shock, you implant the Impala, or in patients who need ECMO, if you implant the ECMO first, then they do well compared to the patients who we implant later. So device before the revascularization. So the timing is important. So 27% chance of death at 1 hour, 50% at 16 hours, and more than 75% death at 32 hours. But in India, by the time you decide for MCS like Impala, by the time you call the company and by the time the company brings and you implant it, most of the patients are in this group for 24 to 32 hours, where you have already gone to the stage of chance of 75% death. That's why the outcomes are bad. So we have to implant it early. So the time counts. The next one is you have to implant it before the revascularization. That is shown in all these trials, unloading. So MCS before. So when all these were put together in the Detroit CSI shock, as well as the National Cardiogenic Shock Initiative, we were able to differentiate or phenotype with the right heart catheter. If you put a swan gans and if you measure the cardiac power output, which is a very strong marker, that is the mean arterial pressure into cardiac output divided by 451. Your cardiac power output is less than 0.6, straight away you're going to need a LV support. If your PAPI, that is pulmonary artery pulsatile index, that is your systolic pulmonary pressure minus diastolic pulmonary pressure by right atrial pressure, if it is less than 0.9, then you're going to need an RV support as well. So you go down the pathway, you get the patient in shock, you do the right heart catheter, your output, cardiac power output is less than 0.6, calculate the PAPI. If it is more than 0.9, RV is normal, then LV support is enough. Then you can just give an Impala. But if the PAPI is low and you have other parameters to suggest there is RV failure, then you need to consider either a bipella, that is Impala with Arbella, or an ECMO support. If both are good, CPO is more than 0.6, PAPI is more than 0.9, in that case, this might be in the A and B category, where just inotropes and sometimes the IABP is more than enough. So the phenotyping with right heart catheter is very vital. And that's what was done in the National Shock Initiative. When they categorized it, stage E was about 27% of patients, stage C and D was about 73% of the patients. In those sicker groups, they were able to get a 79% discharge, and in the E group, a 54% discharge for the first time, which is very, very impressive results compared to what we had for 40, 50 years. When we added hospital-based protocols on top of that, there was a clear evidence that in this particular study, June 2017, up to this point, December, there was no protocol-based. Once the protocol-based was added, there was an impressive improvement in survival. So having a team as well as protocol does help to save lives. On top of all of this, what is important is the shock is dynamic. it keeps changing. So we need to keep monitoring them with the lactate levels as well as other powerful predictors like the cardiac power output, as I said. Sometimes one MCS support is not enough. You may have to escalate from a 3.5 to 5, or if the RV is starting to go down, you need to add RV support with an RV or with an ECMO. So the therapies are dynamic, and we should be prepared to escalate our therapies as needed. When we adapt all these sort of strategies, then we will reach the stage of about that 70% plus survival rate, what was shown in the shock initiative. So to summarize that, when you have a patient with shock, just one, get the parameters, get your cardiac power output, get your PAPI, see where the patient is. If there is RV failure, you're going to need RV support. If there is biventricular failure, you're going to give ECMO support. If it is purely LV failure on this part, then if it is A and B stage, IABP is enough. CDE stage, depending on patient's seriousness as well as the availability, Impella 3.5 and then to 5. If there is RV, then ECMO is going to be needed. So that's how it is. So just show one quick case example. This patient was the first Impella assisted heart transplant with cardiogenic shock. The 63-year-old, multiple comorbidities, severe LV dysfunction. He had out of hospital cardiac arrest. He was brought in, he was continued with resuscitation, and his lactate was more than 10. So he was very sick. He was in the category E. That is the echo. There was no movement. Severe LV dysfunction. So patient was shifted to cath lab. The first, as I said in the protocol, is you put a swan and identify what is happening. In our setup, we can still use an IABP initially until you make a decision. You don't hold IABP. You put the IABP, make the decision. And in this patient, Impella 3.5 was immediately put and lactate reduced to 2 after 12 hours. And that's how obviously you see the femoral access, because it makes it easy. You don't need to wait for the surgeon. And you get this one first, get all your parameters. Once the parameters are obtained, IABP, and convert it into Impella. And that was before the Impella, you see the hemodynamics, and that was after the Impella, see the impressive change you get with the Impella support. But more than implanting, you should be prepared to monitor it continuously. This is on day one. As soon as the patient was shifted, the blood, urine was looking bloody. You reposition the Impella with the echo support, then it was clear. So repositioning and monitoring is very important. On fourth day, it stopped on its own. It's very unusual. So we had to convert it into axillary Impella. It went for another 13, 14 days. We were planning for a permanent LVAD. On 14th day night, again, this second Impella stopped. So we converted to BA ECMO for 12, 14 hours. By that time, organ was available. So LVAD was not done. So the conversion from a sort of Impella to ECMO is very easy. You already have an arterial access. You remove the Impella, and over that, you wire it, and you get your arterial catheter over that. This is the Impella second time implanted. That was after the Impella, he was mobilized for 2 weeks. Right. Now, this is conversion of the Impella to ECMO. So you will upsize the venous and put a venous cannula, and you remove the Impella and use the same arterial access with a stiff wire, convert it into arterial ECMO cannula. So it takes literally 10 minutes to convert. So the patient is doing well now. It's 2.5 years, he's doing well. But obviously, we should be flexible with all this MCS support. That's very crucial. I'll just skip this for the purpose of the time. I'll just show you the algorithm which we use for our protected PCI. This I think we already covered this. So refractory shock, decide whether it's biventricular or LV dominant or RV dominant. Do your CPO, do your PAPI, and decide on what we need to do. Impella or bipella or Impella and ECMO, depending on the phenotype of the shock. With regard to protected PCI, case examples I'll show you next time around. But this document is very vital. Obviously, this is pertinent to our Indian subcontinent. It's a consensus document put by all of us together. A clinical expert document on the percutaneous different classes device during complex PCI. The scoring system, if you have a high-risk PCI, You look at the patient, you look at the hemodynamic state, patient characteristics, coronary anatomy, procedural characteristics, and you score them. If the score is more than 5, you need to strongly consider for an MCS support. 3 to 5, which depending on the patient's affordability and other things, and we can consider. Less than 3, you can just do conventional PCO. So that was the consensus documents put together, and so in terms of decision making, it helps. Weaning, obviously, there's a weaning algorithm that is available. So whenever we think about this MCS, it's very important that it's not one person. You need to have a good team, interventionist, cardiologist, cardiac surgeon, and also a whole sort of host of teams. More important is when you start putting this MCS devices, you need to know where you are going, whether you are bridging to recovery, bridging to transplant, bridging to other aspects. So it's important to understand that every mechanical support device has got its own strength and weakness. IABP still has a place in cath lab and shock. And selection depends on the phenotyping, and we need to understand if it's one cancer. Also, multidisciplinary approaches needed in terms of deciding for the best outcomes. So thank you. Sorry about this protected PCI cases. I couldn't put together because I just had only today time. But probably next time around, I'll show some protected PCI cases. Thank you. I'll take some questions.
Thank you, Dr. Anantraman. That was a wonderful presentation. I particularly liked the algorithmic approach, and I particularly liked the fact that you emphasized the importance of the team, which takes care of the patient. And it's also important that we step in early when we are seeing a shock patient. We'll take some comments and questions from our chairpersons and panelists, please.
I would like to ask a question. Sorry, I've got laryngitis. But many times we have patients with acute MI, and they are in shock. We do the angio, and we find the left main 100% occluded. We are most tempted to put in a wire and establish flow, and of course do an IABP also. So should the sequence be first IABP and then, or establish the flow first?
No, that's a very important question. So once you know that it's an acute MI situation, if it is within that window period, less than 60 minutes window period, the reperfusion is a key. But if you are beyond that, and even if there is a left main occlusion, it's important to give some support. So you can put the support. Time permits, it's also important to get your right out measurements, because we forget that proximal LAD and left main, it is just not LVL. About 30 to 40% of the proximal LAD and left main occlusions will have significant RV dysfunction. So we will have to restore flow. That is the aim. But after the IABP, once you restore flow, if you are still struggling, if the pressure is not coming up, if you are still struggling, that means you have kind of missed the RV side of things. You were thinking that I have restored the flow, but why is the patient still persistently hypotensive? Either you do the right out the beginning, or once you restore the flow, at least at that time, the patient is not improving, you put a right out and check it, and it will tell you if the PAPI is less than 0.9, and you are dealing with a biventricular failure, just not a left ventricular failure, and you have to think about escalating the support. So it all depends on the presentation rather than just one. But in this current scenario which you have given, I would probably go ahead, do what you did, IABP, restore flow, but at least have a low threshold to check the RV side before leaving the cath lab.
This is a fantastic overview. Thank you very much. I really did enjoy it. And it really shows that it's important to have shock centers and centers of excellence where they have the expertise and they have the protocols to escalate, de-escalate, deal with complications, leg ischemia, bleeding, etc., especially the vascular complications. So centers that don't have those capabilities, and we talk about transferring patients. When is the right time to transfer these patients who are in shock, and what are the requirements for the actual transport, in your opinion?
That's very important. Now, if you have a patient in your center presenting in shock like the one I have showed, transferring them before stabilizing, you will lose the patient. How much stabilization you can do there, as you said, depending on the expertise. Most of the cath labs and most of the centers can provide a balloon pump. Balloon pump should be done. Whatever the shock is, balloon pump should be done. The second thing is you contact the center, give the patient details, they come and establish. That's what we are doing. We go and establish an ECMO or Impella, whatever it is, in that place, and with the MCS, transfer the patient. Because transferring without establishing in a shock patient from a center to another center, there's a good chance you will lose. The second thing is transporting with either balloon pump or ECMO through air. Air transfer is a completely different thing. A lot of things we change. The balloon pumps, we reduce the kind of helium kind of. The ECMOs, there are certain ECMOs which are easily transferable. The macro ECMO system is easily transferable. The other ECMO systems are not transferable. So all those minor sort of adjustments we have to make on how we transfer. We have transferred patients through air ambulance with ECMO as well, with the macro system. But obviously all these logistics we have to work out with what MCS we put in. So it all depends on how nearby the center for your support is and how far you are from that center.
Dr. Asha, you're on mute.
I have a question. Is it okay?
Yes, Dr. Veena, go ahead.
It was a wonderful presentation, sir. Congratulations. How do you deal with the coagulopathy issues in patients with these MCS devices in patients who also have basically a thrombotic milieu of presentation, either with coronary events or ACS situations?
No, majority of the, whether it's Impella or whether it's ECMO, there's a coagulation protocol. We follow that. The heparin is the standard and the ACT we maintain it. But some of these patients, when you have issues, when you have heparin-induced thrombocytopenia or other issues, then bivalve is the drug of choice. If you have a bleeding issue on top of that, especially when I'm using ECMO, the current cannulas allow us to run the ECMO without heparin even for sort of 4 days, 3-4 days without any issues because these are already potent. So we don't need to worry. So the bleeding, if the patient is bleeding on ECMO or the patient is bleeding on the Impella, I can kind of take it out for a period of time. If the patient is having heparin-induced thrombocytopenia, then we can change it to bivalve. So various sort of changes we can do. In terms of monitoring, ACT is still the preferred method of monitoring. But in between, at least once or twice, we do ABTT to reconfirm it. But ACT is a monitoring and keep it around sort of 150 to 200. That's more than. But the hemolysis is different. I showed the hemolysis, the urine, you're seeing a red urine hemolysis. That is due to the turbulence in the aortic valve. So you just do an echo. If there is no turbulence, then not reduced turbulence, then you need to repose just 0.5 centimeters, and then confirm it. That's the commonest cause.
Thank you, sir.
Excellent talk, Anantraman. I really liked the 2 points, very, very important. Timely MCS, earlier the better. So the decision needs to be quick. And you're spot on dynamic changes in shock. The shock is never static and it's absolutely dynamic. These 2 points are absolutely important. And when you decide on MCS upfront before PCI, rather than during PCI when you have a complication, is beneficial. These 3 are absolutely fantastic points. Now, I would like to know from you, you have both ECMO and Impella available. And ECMO is more in place than Impella. So when do you choose an ECMO with IABP versus Impella?
Right. As I showed in the algorithm, if you are dealing with a patient with hypoxic issue, apart from hypotension, if you need oxygenation, then there is only one thing, that is ECMO. There is no option, so we have to give. The second thing is, if you've done the right short catheter and you see the CPO is less than 0.6 and the PAPI is also less than 0.9, where you think RV support is going to need it, at this point in time, LV and RV support with Bipella is very expensive in India. It's almost immediately it crosses 60 lakhs. So in that case, ECMO is better. So in that case, I will combine ECMO with an IABP because your LV will not distend and you will still be able to give the patient an affordable solution. So the first you do the right heart, PAPI is low, CPO is low, ECMO is probably fine. If the PAPI is fine and it is purely a left heart failure, then Impella is fine as long as the patient can afford.
And when you keep Impella for a prolonged time, like 14 days, is it important to also do an antegrade limb perfusion like you do in an ECMO, or how is it managed? The vascular component.
Usually with the Impella, especially with the current generation Impella, we get away with it because it's around 12 Frenchish. We get away with it, even though it's say 14, but it's is only 12 or sometimes 10. So we don't usually need to give a distal perfusion unless the patient is very small and you already had some peripheral vascular disease and you are worried that the Doppler is showing reduced flow. Then you can always add it. But for ECMO, it's always upfront. When I'm puncturing first, I just take the distal first, then I do the proximal before putting the large cannula. Once you put the large cannula, it's very difficult to get a distal perfusion cannula. So that's the way it is. Ultrasound guided distal perfusion cannula first, then the antegrade in terms of the Impella. Most of the time it is forgiving, but keep monitoring every day. You should have a chart end of the bed, distal perfusion, the urinary sort of hemolysis, morning and evening, and an echo to see the hemolysis AR. And it's the same for the ECMO. We have a chart. We look at the AR, we look at the LV distension, we look at the dimensions. Very important. Every day, morning, evening. Yeah.
I think we had an amazing set of questions being discussed. Dr. Anantraman, thank you so much. And I do agree that, the Impella is a very forgiving device. We've never had those issues. The one issue that we always had when we used Impella was the hemolysis, for which you ultimately have to reposition, most commonly seen and most commonly corrected also. So it's been a great presentation, Dr. Anantraman. For want of time, we will move to our next presentation. And at this point, I would just like to tell everybody that we are now going to have two cases presented by our international fellows of the WIN APSIC, of which Dr. Mirwat Alasnag is the chair. She's the current chair of the WIN APSIC. And we have Dr. Kartika Karo, and she is the solitary cardiologist running the entire center in Ratnaprapat General Hospital, Indonesia. So Dr. Kartika, we would like you to present.
Thank you, ma'am, for the nice introduction. Whom I respect all the core members, chairperson, keynote speaker, panelists, and all the participants. In this opportunity, I will share a case that I have done in my center. Hope I can have many from the expert about my case. So I will first share screen. Are my slides visible?
Yes, they're visible. Can you go to slideshow?
Okay. Thank you. In this opportunity, I will share a case with the title "Pressure Wire Alone May Not Be Perfect When Anatomy Trump Physiology." So this case is about the use of FFR in acute coronary setting. As a brief introduction, we know that FFR in stable angina pectoris is well established and recommended in current guidelines. But how about the value of FFR in acute coronary syndrome? So now we first go to the case. This is the case of women with 68 years old came with the presentation of acute coronary syndrome with the risk factor hypertension, diabetes, and dyslipidemia, and with stable presentation in emergency department. From the first ECG, this is the first ECG in clinical in private clinic we can appreciate this ECG with sinus rhythm with ischemic in inferior lid. And this is the ECG in emergency department. And now the ECG become atrial fibrillation with ischemic in inferior lid, and also the rise of the troponin E level to 10.4. So we assess this patient with NSTEMI, high risk, and we plan to do early PCI. We give aspirin 300 in emergency department, and we plan to give the clopidogrel in cath lab. So we do angio. This is the angio of the patient. This is the left system. We can appreciate that there is stenosis about 60 to 70% in proximal LAD. And this is the circ. The circ looks normal. And this is the RCA. We can appreciate that there is a site stenosis in distal RCA. We refill this angio with CAD2VD with culprit in distal RCA. From this angio, I plan to do FFR first to LAD so that I can make decision to do complete revascularization or just do the culprit only. And because I have FFR, I also plan to do FFR to RCA just to see the comparison of FFR before and after I do PCI. And I will do the PCI to the RCA. This is my plan. This is the FFR of LAD. We do the FFR and we found RFR was 0.92. And we continue to FFR with, and we give adenosine 200 microgram. And the result is 0.91 and 0.87. So we conclude this lesion was not significant. So we plan to do just the culprit only PCI. But before do the PCI in RCA, we do FFR in the RCA. But the result is very surprisingly, and I don't expect this result. The RFR is 0.98, and the FFR with adenosine 100 and 150. We found the value of FFR is 0.99 and 1. So in this setting, what to do? Go forward stenting, deferred, or leave it for OMT. But because of the value of FFR in acute coronary syndrome, especially in culprit lesion, is not well established, so I just decide to go forward for my first plan to do PCI in culprit distal RCA. So we put floppy wire to the distal RPL, and we do predilatation with semi-compliant balloon 2.5 15 millimeter. This is after we do the ballooning. After we do the predilatation, we pursue to stenting with Promos Premier 3.5 23 millimeter, and then do the post dilatation with NC balloon 40 10 millimeter, and the result is good. No dissection, no perforation, and good TB flow. And this is the echo after we perform PCI. We can appreciate good result from this echo with good wall motion, and also no regurgitation. And this is the ECG after we do PCI with resolution of the inversion in inferior lid, and now the rhythm become a sinus rhythm. So discussion from this case is what is the optimal timing for evaluation of FFR in non-culprit lesion in the context of acute myocardial infarction. So FFR we can do early or deferred. Early we can do during index PCI or within 24 to 72 hours. There's advantage and also challenges in do the FFR in the early phase. Advantage of doing FFR is we can streamline decision making after we do FFR. But in this case, I think the value of FFR make me confused whether I have to do the PCI or I just deferred PCI or I just left it for OMT only. And the challenge also, there's a challenge for doing FFR in early phase because there's still microvascular dysfunction that can elevate resistance and can falsely increase FFR values. Maybe this is happen in this case. So the FFR values is increased and not give the good result. And also the early value of FFR also there's inflammation and acute changes in coronary physiology may not reflect the lesion through ischemic potential. And FFR value measured during the acute phase may be underestimate the severity of stenosis. And how about deferred FFR? Deferred FFR we can do 1 to 4 weeks post acute MI. The advantage in this phase, the coronary physiology more stabilized and improving the reliability of the FFR measurement and allow the resolution of microvascular dysfunction and better assessment of lesion severity. And the challenge is delaying FFR may require additional procedure, increasing cost and procedural risk. And in interim time, there's uncertainty remains about whether significant non-culprit lesions are causing ongoing ischemia or not. So what guidelines and studies say in essay guidelines suggest that FFR or other functional tests for non-culprit lesion may be deferred to a stage procedure unless clinically necessary during the index event. In Flower MI trial, they highlight that routine FFR guided PCI of non-culprit lesion during acute MI did not improve outcomes compared to angio guided PCI. And non-culprit lesion PCI is recommended only for the lesion with clear functional and ischemia significant. And the timing should balance the risk of residual ischemia with the accuracy of physiological assessment. So the practical recommendation is for hemodynamically stable patient, we consider deferring FFR assessment to 2 or 4 weeks post-acute MI for great accuracy. And for hemodynamically unstable or high-risk patient, early FFR evaluation may be warranted if the non-culprit lesion appears critically on angiography. There are many trials to prove the value of FFR in acute MI. One is the prevent trial, which is in this trial, non-FFR positive plaque assessment of plaque anatomy is play important role. So in plaque with high risk plaque, whether the FFR is non FFR positive, doing the preventive PCI is superior to just leave the plaque without revascularization. And also the famous trial, also there are more events in FFR group, less procedural MI. And there is also a study of Sriti and friends in FFR more than 0.5 in ACS. The association of lower fractional flow reserve values with higher risk of adverse cardiac events for lesion deferred revascularization with patient with acute coronary syndrome. So the value of FFR in acute coronary syndrome is still not well established until now. So as conclusion, FFR for non-culprit lesion in non-STEMI with multi-vessel lesion can guide us to do the revascularization complete or just culprit only PCI. FFR for culprit lesion in non-STEMI, if it's positive, treatment is probably appropriate. But if it's negative, we need to think twice before leave it for OMT only. Anatomical profile of the culprit lesion still plays an important role in the era of physiology. Maybe this is a diagram to guide us to do the treatment for the patient with non-STEMI. In non-STEMI with multivessel disease or ambiguous coagulation, first, if we have imaging, maybe we can do imaging OCT or IVUS. If there are a presence of plaque instability sign, we can do PCI. If there's no present plaque instability, we can do physiology study. And after we done physiology study, we see the FFR. If the FFR is less than 0.8 or IFR less than 0.989, we do the PCI. But if FFR is more than 0.8 or IFR more than or 0.89, better we do imaging. If there is a presence of plaque instability sign, we do the treatment with PCI. If there is no plaque instability, we can leave the plaque with optimal medical therapy. Thank you.
Thank you, Dr. Karthika, for that wonderful presentation. The House is now open for comments by the chairpersons and the panelists. Dr. Meerwat, we start with you.
Well done. This was a very elegantly prepared case and very well done. So just a couple of comments. I think for me, doing intracoronary physiology in a lesion that is like the right coronary artery, pretty clearly that this was a very tight stenosis. So any test, you need to ask yourself, what information is it going to give you? And what's the pre-test probability? So you ahead of time, you know that, eyeballing it, this was not an intermediate lesion. This was actually a significant lesion. And so the yield from physiologic evaluation of that test is probably not going to guide your management. If you want, it probably, as you just showed us in the last slide, maybe intracoronary imaging will help you define the morphology better to decide how to treat it or size it and so on. So that's point number one. And then, as you elegantly put again in your slide, that there are reasons your physiologic testing may be falsely negative, particularly in the acute phase, where sometimes you have microvascular dysfunction, and sometimes you have what's called balanced interruption because you've got multi-vessel disease, and so it doesn't give you the yield that you want. And they haven't been validated in patients with very high EDP, so such as patients with aortic stenosis. So those are the things to take into consideration with physiologic testing. So the only other point that I would have made is the PREVENT trial. It was a very well done trial, but we need to be very careful about interpreting preventive stenting in patients. I mean, vulnerable plaque, maybe the solution is not necessarily a stent. It may be just, stabilizing it with lipid lowering or with, for example, antiplatelet therapy. And the reason I say that is that in the PREVENT trial, the reduction, of events was actually pretty low. It was statistically positive, but you needed to treat a large number of patients to only reduce, I believe it was a total of 13 events, of which only something like 3 or 4 were actually deaths. The rest were all revascularization down the line from the stenting that was actually done. So we just need to be a little careful about how we interpret the PREVENT trial. But really well done. And again, I really need to use this opportunity to thank Dr. Sarita Rao, because she's been championing this fellowship program for women in cardiology for WIN-APSIC for several years now, and really has done a phenomenal job representing our group and making this materialize. So hats off to her for all the hard work she's done. Thank you, Sarita.
It's my pleasure entirely.
Thank you very much, Dr. Meerwat.
Dr. Madhuman,
Yes, ma'am. I have a question. Can I ask, ma'am?
Yeah.
please go ahead.
Good presentation. Congratulations. I have one question. In acute MI patients, what's your experience in FFR versus IVUS in such lesions, in acute MI conditions? Which is superior, FFR versus IVUS?
Thank you very much, Dr. Madhumanti. Actually, in my center, I don't have IFUS or OCT, so I just have physiology like FFR. So for the RCA, actually the first I don't want to do the FFR, but I just wondering the difference FFR before and after the PCI, but the result is surprisingly normal. So it make me confused. What should I do like this about the IFUS or OCT? Unfortunately, in my center, until now, we don't have. We just have IFFR. Thank you.
I think it was more for curiosity or your educative purpose that you
Yes,
wanted
yes,
to see what would be the difference. But
yes,
like Dr. Mirvat rightly said, if you should know why you're doing it. Like if your pretest probability for RCA, anyways, you were going to do it, the plastic. And LED non-culprit lesion, usually at the index event, sometimes you would rather not touch. So we didn't benefit from the FFR. You got more confused. So
yes.
that that was one thing. But otherwise, you made a great effort, and I think it was interesting for all of us to see that it turned out to be normal. I mean, I was surprised.
Ma'am, I have one.
Yeah.
Dr. Magellan, please go
Yes,
ahead.
ma'am. Thank you so much, ma'am, for the opportunity. It was a great case, ma'am, and a lot of learning points. As Dr. Miravat, ma'am, had mentioned, to identify the vulnerable plaque in the non-culprit vessel, the newer, the mu FR based on the Murray's law, at less than 0.9 will give us an idea on the non-culprit if it is a vulnerable plaque. Your opinion or the expert's opinion on that, ma'am. It's a newer entity which is come recently published in the EuroPCR. So to identify the vulnerable plaque, mu FR based on the Murray's law, the quantitative FR, it is with a single angiographic technique it can be done, and the values less than 0.9 is suggestive of a vulnerable plaque along with the radial wall strain. Your thoughts and your expertise opinion on that, ma'am.
So, would anybody like to answer that? I don't think any of us have used that as yet, Dr. Magella.
Yes,
So,
ma'am. In India, it hasn't come it, ma'am. It is
yeah, so
just
we
it
haven't,
as yes, ma'am. It
yes.
hasn't come into India, but it has been very well established in the Chinese as well as the US has approved it. And in the recent Euro PCR, they've suggested that if we normally we do the OCT to identify, or we need a higher end virtual histology IVUS imaging, which is a more costly affair. But when we combine a radial wall strain, if it is more than 13, along with the mu FR, which is based on the Murray's law, the quantitative assessment, if it is the mu FR is less than 0.9 and the radial wall strain, which is more than 13, then this assessment will help us to identify the vulnerable plaque, and that will help us to identify these so that we can prevent the major adverse cardiovascular events and put them on aggressive medical management. As Miravat ma'am rightly said, need not stent them always, but there are also studies that this can be prevented. This vulnerable plaque, a biovascular scaffold can help to prevent future MACE events. There are two arms on that. One on aggressive medical treatment, and the other end we can put in a biovascular scaffold. The simple angiographic can help us identify those plaques and prevent MACE events. So this is the newer this thing, ma'am. It
I'm
hasn't
sure.
come into India. Yes, ma'am. But it is
I'm sure
definitely very useful.
we'll
It will be the
definitely,
future.
yeah, we'll definitely look at this once it comes into India, and we'll definitely try it, and we'll definitely look at what further studies say about it. And yes, imaging can definitely help us in many ways, which only physiology cannot. But as Dr. Kartika said, in her center, she has only physiology. And I think in this case, what happened was that she wanted to look at the non-culprit vessel physiology. And because she had the FFR on table already open, she thought, okay, let me look at this. So maybe I can do a pre and post and see how it improves. And that was the time she got a surprise because her FFR came out to be normal. So in the interest of time, it was a great presentation, Kartika. And thank you so much for that wonderful presentation. And we will move to our next presentation by Dr. Doreen Sampat. She was the fellowship winner from last year. She's from University Malaya Medical Center. And she's going to be speaking about DCB in ostial LAD occlusion in a geriatric patient. Dr. Asha has just put into the webinar chat. Kartika, message for you. Excellent case with many newer trials and thought-provoking discussions.
Okay, thank you, ma'am. Thank you.
Any comments by any of the chairpersons meanwhile, or any discussions? Dr. Sujata, Dr. Jyotsna, Dr. Asha?
Congratulate Kartika for bringing up many interesting aspects. When it comes to chronic coronary syndrome, it is very clear what is the role of FFR. But in ACS, it's still controversial with trials not very supportive. You have microvascular dysfunction, you have inflammation. Of course, in a culprit vessel, there is not much point in doing an FFR. As everybody agreed, imaging is a better modality there. But of course, you had an FFR, you have opened it, you wanted to study it, no harm, provided it is safe to do so and patient is tolerating it, hemodynamically stable. There's no harm in doing it, and it's kind of an experimental purpose because you've already opened it and you're anyways going to use it. But I thought the LAD, if I had just looked at it angiographically, it looked a little hazy with a little slow flow. I would have just stented it.
Entered it.
That's the point. I just want to ask all the expert here.
I would
What should I do to the LAD?
as well. First fix the RCA and then gone ahead and done the LAD. Sarita, what would you have done?
So angiographically, that LAD looked significant, but that's the beauty of physiology. Many a time, what looks significant angiographically is not significant when you do the physiology testing on it. And so it came as a surprise that the FFR was negative. But scientifically, if she has a negative FFR in that, she's perfectly right to have left it. But yeah, if we had not done the physiology and we'd just seen that, we'd probably fix the culprit. If the patient was stable, we would have fixed the other vessel. If not, maybe stage it to the next day and do it the next day.
Yeah, I think the Kartika, you are the dare enough to get a new idea to do in acute coronary syndrome. Because unless someone does these things, we don't know about it. Now it is very easy to comment that that is not an indicator to do it, except in the chronic because that is an established. So you're dare enough to see that. But what I think is that is okay, acceptable. For me, it is not looking like really requires a physiological assessment for that. That's what I thought. And the second one is I wanted to know why you wanted to give a clopidogrel in the cath lab. Why you don't want to give it along with an aspirin before itself? Because anyway, it takes minimum of the 600 milligrams. It takes 2 hours. So why you want to give in the cath lab?
Yeah.
That is your protocol.
Few cases that we have done that NSTEMI patient came with the multivessel disease, 3 patient with maybe 3VD with critical element. We want to do KBase for the patient. So in my practical in NSTEMI patient, I do maybe the first in the emergency department. I will load 300 and I will add in the cath lab 300 more, ma'am.
Actually, what you said is true for the prasugrel. So they used to say that if the patients requires surgery, then it's better not to unless you know the angiogram. So that's the reason why the prasugrel was used to be told. But nowadays, for the CABG also, they're giving the dual antiplatelet drugs. So I think probably you people can have a local discussion whether to modify that or not. That is good enough.
Current
Is
ESC
there-
guidelines for non-STEMI says if you're
No preload.
immediately do not load the patient. After knowing the anatomy, you can give. And now you have ticagrelor, which is much faster acting, so it really does not matter. Unlike the earlier clopidogrel. So the current recommendation is if you have an immediate angiogram available, then do not load. If your angiogram is going to be delayed, then probably you can load the patient.
Yes, surely, ma'am. And ticagrelor, even the guidelines support. In fact, when ticagrelor came over prasugrel, this was one of the advantages that even, fibrinolysis as well as CABG. These are the two things which we got advantage, which was not a feasibility once prasugrel has been administered, because we need to withhold the drug prior to the CABG, and we cannot thrombolize the patient at all, if at all, even if we want to. So this was I thoroughly agreed.
Thank you. We do have now IV cangrelor as well available. So if you really
yes,
a quick
yes,
action, you can always give an IV
yes,
cangrelor as well.
surely, yeah.
Dr. Sujata has joined. Dr. Sujata has joined.
No, Doreen is ready. I think she's trying to share her screen. I agree with Asha. Preloading is not recommended in the ESC guidelines. That's what. Though in India we are always preloading. Okay. Yeah, and in 4% of patients with more than 90% stenosis, the FFR comes negative. That's the so. Dr. Doreen, she's trying to connect and she's trying to share her screen.
Saw that she's Dr. Kumar, any update from Dr. Doreen?
Yes, ma'am. She joined. She has some technical issue, ma'am. So I'm messaging her. She joined.
May I ask a question, Sarita ma'am, by the time she's joining, if we have 1 minute? I need to understand, like we do FFR as a physiological test for the lesions, which are significant. What is your thought process about the plaque burden that we get on IVUS vis-a-vis, FFR? If the patient is symptomatic, I mean, for these lesions, I've seen people stent lesions, which are having plaque burden, which is significant on IVUS, and visibly, angiographically, so many of the times they look normal, and even FFR is fine. What is the take on this of the house?
There is this flavor trial, right, which says fractional FFR versus IVUS for patients with intermediate stenosis. And there is no difference between FFR guidance and IVUS guidance. This is one of the trials which compare two different modalities, anatomy and physiology. So, and also there is a statement that if you want to stent, you do IVUS. If you don't want to stent,
yeah, I know, I agree. So I witnessed this in a patient who was stent.
Basically, Dr. Shiba is saying that only. That the FFR came negative and the IVUS came positive.
Yeah,
what do you
so
do
I've
in
seen
a situation like that?
Yes, it happens. And then I look at the plaque characteristics. To me, if it looks like an unstable plaque, I would definitely stent it.
So I feel the clinical history and the clinical scenario and how the patient, whether it's what's happening to the patient is, thoroughly agree.
Yeah, more important. If it is an ACS, definitely I would.
Yeah.
Thank you, everybody, for joining in. It's been a wonderful first meeting in 2025. A very happy new year to everybody. And it's been great discussion, simulating our thought processes. Thank you, everybody. And thank you, Dr. Kartika, Dr. Mirvat, for joining in. And thank you, Dr. Amantraman, for the wonderful lecture. Thank you. Good night.
Thank you, Sarita. Great start and great effort.
Thank you,
Good night, everybody.
Good night.